next speaker, who's Professor Nuh Rahbari, who's Professor and Chief of Surgery in Ulm in Germany. And to quote a line from Top Gun, you will probably not find a finer young clinician scientist in HPB anywhere in the world. So we're really pleased and proud to have Nuh here to talk to us today. Thank you very much.
Thank you for the kind introduction. Just to extend the spectrum, I'm going to add the German accent now. First of all, thank you very much for having me. I'm really enjoying this conference. Excellent presentation, excellent talks, and I'm learning a lot. To start with, I got to tell you, I got scooped. I'm about to present this trial, but Iswanto just presented the results yesterday, but I will forgive you. If you're about to give a talk on robotic hepatectomy and you could pick one person to scoop you, then it would be you. Anyhow, so maybe I get through this quite quickly and we can catch up on time and get some time for discussions. Now, you will ask yourself, where the heck is Ulm? Now, Ulm is a small town in the south of Germany, an hour from Munich. I moved there about a year and a half ago. As you might expect, I'm quite interested in liver surgery, so we were able to ramp up the program there quite significantly. And as you can see from this chart as well, we like the robotic approach so much that we actually were able to get a second XI system a few weeks ago. We have two robots, but we just have one. Dr. Birgen, he's the author of the manuscript, and he deserves the credit for performing the trial. I'm just presenting on his behalf. Now, let's get into the topic of robotic versus laparoscopic hepatectomy. As you know, we've been doing laparoscopic hepatectomies for quite some time. The first one that has been reported was in 1991. These days, we can do them quite routinely. I just show you an example of a case, a lady with a complex cystic lesion in the posterior sector. It was not a hydatid cyst, but our radiologist could not exclude malignancy, so we decided to take her to the operating room. In this case, planning to do an extended posterior sectionectomy, taking the right hepatic vein in order not to, or to avoid opening the cyst. And also, as you take the right hepatic vein, to do a subanatomical resection of segment 8. Now, what we like to do, I'm a big fan of anatomic resections using the X-ray pedicle Sony pedicle approach. So we clamp the posterior pedicle, give ICG. As you can see, you can, of course, do this laparoscopically as well. Then use the right hepatic vein as a guide to the IVC. I'm not a CUSA person, but you can also, of course, use the CUSA. Then take down the posterior pedicle, go along the IVC to find the root of the right hepatic vein, take it with the vascular stapler, then mobilize the right lobe, and then you're done with your laparoscopic hepatectomy. Now, moving on to robotics. The first robotic hepatectomy was reported in 2003. I'll just show an example of that as well. An HCC in segment 8. It's a little hard to see on this scan, but there it is. And we plan on doing a real anatomic segment 8 hepatectomy. So we want to see the hepatic veins naked. So what we do is a top-down approach, marking the course of the middle hepatic vein using the intraoperative ultrasound, and then going from top down. I used to do the Hylar approach, but found it to be risky in terms of getting biliomas. So now I moved on and using the top-down approach using the middle hepatic vein as my guide to the segment 8 pedicles. Here we took the segment 8 vein branch and then marking the resection plane, moving on, isolating the lateral and dorsal segment 8 pedicles, taking them with clips. And then once we've done that, give ICG intravenously to see the real resection plane and demarcation between border between segments 7 and 8. Moving on to the right hepatic vein, also clearing it off the parenchyma. As you can see, we only use monopolar scissors and bipolar forceps. We published on this. We call it the scissor hepatectomy without any energy device. Now, we can do this, both approaches. We feel comfortable doing them. And as you know, there are randomized trials on laparoscopic hepatectomy, but there hasn't been any trial on robotic hepatectomy. So we decided to do this trial, the ROC'N'ROLL trial, comparing both approaches as we were experienced in both techniques. Now, what is the design of the trial? We used quality of life as a primary endpoint. This gave us a pretty hard time with the reviewers who were not convinced that this is a good endpoint, but we can talk about this later. We assessed it preoperatively and then at the predefined postoperative time points, randomized a total of 80 patients and stratified the primary endpoint for the type of malignancy and the difficulty score. And we're able to finish the trial in quite a short period of time. This is the trial flow. I can go over this quickly. This is our patient cohort. I would say a pretty typical cohort for a Western institution. And this is the primary outcome. As you know, there was no significant, or actually no difference at all in the primary endpoint quality of life. Also, if you looked at the items, there was no difference between both groups. Now, the surgeons were, of course, interested in our real surgical outcomes. If you look at morbidity, it was quite interesting. It did not reach statistical significance. However, there seemed to be, a trend. I hope there is no statistician in this room. I know they don't like the term trend, but I would say there is a trend to lower CCI in the robotic group, and there was also no difference in time to functional recovery. But again, it looked like the robotic group did a little better than the laparoscopy group. No differences in uptime and blood loss. However, slightly more conversions in the laparoscopy group. Now, of course, this trial has limitations. You can, argue there is the sample size is small. It is a single center trial. We can discuss about the primary endpoint, and also we did a trial on essentially all comers, except for patients who needed vascular or biliary reconstruction. So we had, a certain amount of patients with low complexity cases that may not necessarily benefit from the robot. So taking everything together, it's the first trial on robotic hepatectomy. It did not show a significant difference in quality of life, but there was a trend towards lower complication rates and conversion in the robotic group. Now, let me just take a minute to tell you that we are giving robotic and laparoscopic workshops. It's 2-day workshops in Ulm. The ones that you might be interested in are the robotic hepatectomy workshops. These are done together with Intuitive. So if you're interested, just shoot me an email, and I'll be happy to have you in Ulm. Thank you very much.
Yeah, hi, Dr. Rahbari, very interesting presentation. When you're actually choosing, let's say you're not doing a trial, which approach would you take and for what indication? I mean, have you got any sort of set views on which patients you use robotically and laparoscopic?
Well, as I showed you now, we essentially moved on to almost all of our cases robotically. The more complex the cases are, the more you will benefit, as you were saying, from the robot as a surgeon, but also I think the patient. I think it's a lot of things coming together. You can do complex cases laparoscopically, but you can do it. But how about your assistant? How good is your access to a very experienced first assistant holding the camera for 6-7 hours? So this can be difficult for you as a surgeon. Technically, it's possible, but do you want to suffer? Do you need to? Should we suffer every day in the OR? I don't think so. So I think the point that she was making about the quality of life of the surgeons, as we are, in times of, lower and lower application rates of residents, I think it's important to think about our quality of life as well. And the more the complex the cases are, the longer they are, I think we as surgeons benefit. But now, speaking as a chairman, we completely moved from almost completely moved from laparoscopy to robotics.
Right, thank you very much. Myro Clark, who's going to tell us about Kemal's contribution to innovation in wetlands.